So I'm very excited about our lecture this afternoon and for Dr. Knowlton to join our Cancer Center team in our healthcare system. So our lecture this afternoon, what is cancer rehabilitation and how can it help my patients? So our presenter, Dr. Knowlton, our top 5 things, what do we want to know about Dr. Knowlton? She creates a personalized cancer rehabilitation program for each patient. Her clinical and research goals focus on improving the quality of life and functional independence for patients with cancer. She received her degree from the George Washington University School of Medicine and Health Science in 2012. And then she did her residency at Harvard Medical School Spaulding Rehabilitation Hospital from 2013 to 2016. And she is an associate professor for physical and medicine rehabilitation at the UNC School of Medicine. So Dr. Knowlton, outside of your professional bio, something you'd like to share with our audience about yourself?
Yes, of course. So I am a relatively recent transplant to North Carolina. I moved down here with my family back in July and started here in August, and we're very happy to be here. However, my elder daughter has decided that she is not a Patriots fan like me. She is not a Baltimore Ravens fan like my husband. She is a Carolina Panthers fan. So it is a house divided 3 ways, and my other daughter is going to be the tiebreaker when she decides. So. Okay. So before we start, I wanted to do a poll everywhere question about what is one word that comes to mind when you hear cancer rehabilitation, understanding where we all come from, different walks of life, different practices, etc. So I think it'd be a good question to start with.
So that was just our sample. Here are our disclosures, and then you can test your poll everywhere. And just as a reminder, at the end of our lecture, you'll be able to ask Dr. Knowlton questions through poll everywhere. So make sure you have that either on your phone or you can connect online at pollev.com/UNCLCN. So we have a few words coming in: struggle, function, physical. What do you think, Dr. Knowlton?
So I think this is great because it sort of gives me an overview of what you all think of, and I hope to change that mindset a little bit and expand upon the knowledge that you do have. So I guess I can get started here. Thank you all for participating. So the goal of today's lecture is to really help educate all of you about what cancer rehab is, and just as importantly, if not more importantly, help you understand how it can help my patients, your patients. So the goals of this lecture are, 1, to define cancer rehab and have a good understanding of what it is, and then also list the diagnoses that physiatrists like myself can treat in cancer patients. And because neuropathy is probably the #1 thing that I see and treat, as it is unfortunately quite pervasive, help you identify treatment strategies for neuropathy. So what is cancer rehab? So this term initially started coming into the literature probably in the late 1970s. And you can see that over a few decades that the definition really hasn't changed. Cancer rehab essentially helps someone who does have cancer from the time of diagnosis moving forward all the way through hospice to really help them maintain and achieve maximum functional health, physical health. And of course, incorporated with that are also social aspects and vocational aspects. And cancer rehab initially is thought, to be in the survivorship phase. And I noticed that was one of the terms that kept coming up in the polling question, but it is also available actually before starting treatment for cancer, after cancer has already been diagnosed. We like to say at day 0 or day 1. But there's also services that can be helpful during cancer treatment as well. And the next slide demonstrates an updated definition from ASCO. And I was thrilled when I was, trying to pull things off the internet to see that ASCO has actually included a section on cancer rehab on their website, because now not only am I, preaching to the choir of other physiatrists and therapists that I work with, but on the other side of the aisle, my oncology colleagues have said at a national level, hey, we need to really, investigate this, incorporate this, etc. Which is why it's now part of the Commission on Cancer standards to have a rehab practice, essentially, at any accredited cancer center. So what are the goals of a cancer rehab program? So prior to coming to UNC, I was up in Boston where I created a cancer rehab program up there and came down here with the 3 pillars, if you will, in mind. One of which is clinical, seeing patients currently in the outpatient setting here at the cancer center, but also inpatient consultations as well at UNC Chapel Hill. Getting patients in the door and demonstrating to my oncology colleagues that, hey, it actually makes a benefit and patients are happy seeing a physiatrist like myself and getting paired up with a therapist where needed is really the first aim of a cancer rehab program. The second is research. And there's been a plethora of research really over the past, say, 10 years of different aspects of cancer rehab, from randomized clinical trials to, generic exercise interventions, etc. And then third is education, educating my oncology colleagues on the physician side, but also APPs in this particular setting, which is great. But also patients themselves. They may say, hey, why am I being referred to see a rehab doctor? This makes no sense to me. And also to caregivers to help them understand how cancer rehab can help their overall function. And in rehab medicine, we always like to talk about teamwork. Sure, the physiatrist may be the quarterback of the team, but they're not going to score if you don't have good wide receivers, kickers, etc. So collaboration with oncology teams, therapy teams, and also patients and support services as well. So what are the different components of a cancer rehab program? Not to repeat myself, but it's really buy-in from physiatry and oncology, but also, having good support both here at UNC Chapel Hill and also out in the community of specialized therapists. For example, I need physical therapists, occupational therapists, and speech therapists that are comfortable working with patients with cancer. Otherwise, if I send, someone with post-mastectomy pain to a physical therapist who deals primarily with, high-level athletes, that's not going to be satisfying for the patient nor the therapist, and is not going to lead to a good therapeutic relationship. Additionally, having nursing support, for example, if I need to have someone learn how to straight cath that has a new spinal cord compression from a metastases. Social work, as I said, there's a lot of psychological, social implications to function, and it's all intertwined. So having that support is helpful from social work, but also mental health support. When needed, getting patients in for braces, or if they have, residual limbs and they need a prosthesis, getting them, hooked up with those services, and also support groups. And the whole overarching goal of a cancer rehab program is really to address any pre-existing or concurrent functional limitations that patients with cancer have and allow them to tolerate the journey through cancer treatment and into survivorship in a much better way. So, sorry about that. So I include this for historical purposes. This is what is called the Dietz model. I am not the biggest fan of it, but no introductory lecture on cancer rehab would be complete without it. Really, the model tries to break down cancer rehab into 4 buckets. I don't like it because it tends to box patients in a little bit, and providers sometimes can have blinders on. But I think it's a good thing to review to help set the mindset a little bit. So in the preventative model, or in the preventative section of the model, this is the whole idea of prehab, which I'll get into a little bit later on. But really, it's when patients are first diagnosed with cancer, before they've started treatment, maybe after they've had their biopsy done. A lot of them are not in the best health to begin with. So sort of screening where they are. Do they have pre-existing neuropathy from diabetes? Do they have prior back pain, that needs to be addressed so they're able to function better, etc. Restorative is really, when patients undergo treatment, they have some sort of functional limitation. The goal of that is to get them back to normal, which is another term that I'm not the biggest fan of, but trying to get them back to that 100% level. Supportive is really meeting them where they are, especially if they're during chemo and they're getting fatigue or during radiation, and trying to support them as best as you can. Not getting them back to 100%, but trying to get them to tread water, for lack of a better word. And then there's also a role for cancer rehab in the palliative setting as patients transition into hospice, because maintaining that ability to do what we call activities of daily living, or ADLs, independently is very important for a sense of self. And if there's a role to continue therapy or home exercises so that patients are able to dress themselves, maybe bathe themselves, it preserves that dignity, which is extremely important. So what are things like a physiatrist that myself treats? So this is a list that was published 10 years ago, which makes me feel a little bit old. And it's not supposed to be, all encompassing, but it's meant to give you sort of an overview of the different types of things that I can treat. So just to back up a little bit, a physiatrist is a physician that's trained in what's called physical medicine and rehabilitation. That field for, when I'm trying to describe to my 5-year-old what I do, is really for people with disabilities. So, patients can come in with pain as a disability. They can come in with fatigue. And we have subspecial come in with, generic back pain just because, they had an injury 15 years ago and it's starting to kick up because maybe they're deconditioned and they're not exercising like they should. So it's a good variety of things, but you can see a lot of these things are quite pervasive, unfortunately. So how does a physiatrist like myself evaluate a patient? I look at them through a functional lens, meaning I want to ask them, are you able to do things independently that you should be able to? For example, dressing, bathing, etc. Are you able to shop? Are you able to clean your house, whether or not you actually want to? Or is your back pain limiting you? Is your lymphedema limiting you? So when talking about a functional lens, it's important to identify what impairments a patient has, whether that's a back pain, a dropped foot, difficulty with swallowing, etc. That can help frame what their disabilities are, meaning things that they feel that they're supposed to be able to do, but they can't, which can lead to social handicaps and inability to work a job or do things, at a social level. It's also important to ask, a functional history. What is your home design like? What is the layout at home, etc. And then address realistic goals, which is sometimes a little bit of a struggle with patients who come in, maybe they're a non-exerciser, but all of a sudden they want to jump back, in the game, so to speak, and run a 5K in a month when they just finished radiation therapy 3 weeks ago. For someone who's an exerciser by nature, that may be more feasible, but for someone who's, for lack of a better word, a couch potato, sometimes adjusting those expectations to make sure that you set them up for success is important. So why is function important? Why am I harping on about this for the past 10 minutes? So the ability to do daily tasks independently is vital for a sense of self. For older individuals with cancer who said, we're given a choice of saying you can have this treatment, it'll prolong your survival, but it may cause some functional impairment, meaning that they're not able to do things for themselves or they lose an aspect of mobility. More than 70% of that those asked said they wouldn't want a treatment that would result in functional impairment, even if it improves survival. And not surprisingly, with ECOG scores and KPS scores, prognosis is linked to functional outcome in cancer. And this has been proven time and again in multiple studies. So it really drives home the point that maintaining function, if not improving function, is extremely important, not only for quality of life, but also for prognosis. So what are the predictors of functional decline? So some of these things I can't change. And I tell patients that to sort of lighten the mood. I don't have a fountain of youth. I can't reverse age. I can't change a lot of these socioeconomic and demographic factors. Can I change if they're a smoker? Sure, but that's really hard to do. Other things I can't change are disease characteristics. I'm not an oncologist. I don't decide what treatments they're eligible for, but are there things that I can do, like maybe improve their underlying, ECOG score or KPS score so that they're eligible for more treatment or to continue treatment? Sure. Can I talk to them about, nutrition, and maybe they don't want to see a certified dietitian, but can I give some basic recommendations? Absolutely. So there's some, things that predict functional decline that I can change and things that I can't. And that's where it really becomes important to focus on the things that I can change. So again, why does functional status matter? So for patients, functional impairment, so the inability to do something, results in shorter survival. Makes sense, right? So if you can't walk and you're more prone to fall, that's bad. You may fall and break a hip, you may fall and bump your head and cause a brain bleed, etc. When you have any sort of functional impairment, in multiple studies, it's been shown to increase your risk for chemotherapy toxicity. Additionally, patients who have functional impairments report more symptoms. They have a higher symptom burden, whether that's pain, insomnia, fatigue, etc. The list goes on. And functional impairment is extremely common, unfortunately, in this patient population. Depending on which study you read, depending on which disease category you're in, 39 to 78% of older individuals with cancer report some sort of functional impairment. So let's break this up a little bit. So I talked about ADLs. What is an instrumental activity of daily living, or IADL? And we'll talk about why this is important in a minute. Okay. Give you another, say, 5 to 10 seconds or so. Okay, great. So the answer to this, it was a little bit of a trick question. So ADLs and IADLs are different. So ADLs are things that you do for yourself, that you should be able to do independently, getting dressed, taking a shower, etc. IADLs, instrumental activities of daily living, are things like cleaning and cooking and shopping and balancing a checkbook and doing all those things like that you may want to outsource, but you're able to do yourself if needed. And why is that important? So those IADLs, being able to cook, clean, etc., is specifically associated with improved survival in cancer survivors. So even though those things may be annoying, like I try to outsource cleaning my house, I am able to do it if I need to. And if I had cancer, then that would be associated with improved survival. Additionally, being able to do these things is understandably associated with improved quality of life. Now, this graph I've shown here is not cancer specific, and it's from an older study that was published in 2002 in the New England Journal of Medicine, but it still rings true. And I talked about this a little bit earlier with the 70% number of patients not electing to pursue any sort of chemo, radiation, surgery, etc., if it caused a functional impairment. And this was repeated, 10 years ago in this article, in this graph, that demonstrates when patients are presented with treatment options and there's a low burden but functional impairment or cognitive impairment, with the likelihood of that negative outcome, meaning they develop one of these things as a result of treatment, the number of patients who elect to participate in that treatment goes down. meaning that talking about potential adverse outcomes with patients is important, because if they're given that choice, a lot of them will choose not to have that treatment, depending on the amount of functional or cognitive impairment that's associated with it. So what about, pain? Pain is a huge issue, not only in cancer patients, but outside the cancer world. But specifically in cancer, there's multiple reasons to have pain. You can have pain from the tumor itself. You can have pain as a result of treatment. You can have a fracture, like a compression fracture, either from the treatment, the disease, or because you have underlying osteoporosis. You can also have skin breakdown. You can have muscle strain, etc. And pain, understandably, is associated with function. When patients are in pain, they don't want to do things, right? They want to sit there and be immobile, which is bad. So ultimately, finding the source of pain, finding the cause of pain is extremely important for treatment, because the treatment depends on the cause. If it's a nerve pain, you're going to prescribe nerve pain medication. If their pain is due to lymphedema, then you're going to get them in physical therapy and get them compression garments. Depending on what's causing it, there's different injections you can do, surgeries, etc. So what are some things that I can see and treat as a physiatrist? So one of the things I talked about briefly earlier is spinal cord injury from metastases. So spinal cord injury in the general physiatry population is what we call our bread and butter. They are, our patients that we definitely own. Well, yes, there's some things that are different when patients have a spinal cord injury from metastases instead of, a car accident or jumping off a diving board. But in some ways, the treatment is somewhat the same. If they have nerve pain, get them a nerve pain medication. If they've got spasticity, meaning increased resistance to in tone, depending on how fast you're moving an arm or a leg, get them in for spasticity management, whether that's oral baclofen, whether that's a Botox injection, etc. A lot of times these patients have bowel and bladder and sexual impairments. They can be constipated. They can have a mixed picture where they're constipated and have loose bowel movements all the time and can't control it. So seeing where they are, whether it's an upper motor neuron, a lower motor neuron injury, and get them a good bowel program, get them a good bladder program, so they're not at risk for, being severely constipated. They're not at risk for UTIs and hydronephrosis. And get them into physical therapy and occupational therapy so they're able to function and move around and do things independently. Another case that I see, quite commonly is dropped head from Hodgkin's lymphoma that was treated with Mansfield radiation in the past, or in head and neck cancer. Used to be that we would stick these people in a headmaster collar or a cervical collar. That's not the treatment du jour nowadays. Nowadays, we get them in active bracing. We get them in a good exercise program to work on the strengthening of the bigger muscles rather than the smaller muscles. But there are ways to intervene upon that. Similarly, in breast cancer, when patients have either a lumpectomy, a full mastectomy, radiation, etc., it affects their chest wall and results in a lot of shoulder issues, one of which is shoulder impingement. So maybe they need, an injection, a steroid. Maybe they need to go to OT. Maybe they need to work on some physical therapy to improve their posture, range of motion, scapular stabilization, etc. Talking a little bit more about the spinal cord injury from metastases, I addressed some of these, but another thing that's important to consider in this patient population is hemodynamic instability. A lot of these patients get severely lightheaded when you sit them upright. Depending on where the level of injury is, if it's above T6, they can have a super fun phenomenon called autonomic dysreflexia, and I say that tongue in cheek, where their nervous system, explaining it in a simplicity sake, because a lot of times this is an hour-long lecture for PM&R residents, their nervous system is essentially severed. And so when something below the level of injury, like a tight compression garment or a foot that's caught under itself, or even a fracture, is causing a sympathetic response, it tries to send it to the spinal cord, which it's severed, so the brain doesn't get those messages. And so the brain sends down, as the heart rate's going up and blood pressure is going up, the brain sends down sort of a parasympathetic response. And so there's this huge mismatch, and patients often develop sweating, headache, etc. Why is that important? Because they can stroke out from it. So it's an important thing to recognize and manage in the physiatry setting. As I mentioned, spasticity is common. It can occur with a spinal cord injury. It can occur with brain injury, including brain tumors. Spasticity, though, sometimes can be functionally beneficial, meaning that a lot of times patients who have spasticity in a leg rely on that leg to mobilize. And if you completely knock out spasticity with a Botox injection or increasing doses of baclofen or dantrolene, you may take away that artificial tone and strength, if you will, so they're unable to walk. So this is where the functional assessment becomes really important. At the baseline, though, a really good stretching program is the baseline of treatment. I talked about this a little bit, neurogenic bladder. So it's important to identify if it's an upper motor neuron or a lower motor neuron injury. There's different ways to intervene. For upper motor neurons, there's medications that you can use. It's important to establish a straight cath program, making sure the bladder doesn't get over distended, as it can cause micro tears and cause urine back up to the kidneys, which is bad news bears. For lower motor neuron injuries, you can also use different types of medications, and these address different receptors that are on the bladder itself or the sphincter. You can use the Crede method, double void techniques, etc. Pelvic floor therapy a lot of times can be extremely helpful. The reason being is in cancer, a lot of times these are a mixed picture, meaning it's not clear-cut upper or lower motor neuron, and Kegels are not the answer for this. And I say that as one of my dear friends is a pelvic floor therapist, but Kegels are not the answer. This is where it becomes, important to really consult with a pelvic floor therapist or a physiatrist. Similarly, for neurogenic bowel, it's important to address whether it's upper or lower motor neuron. You want to get the stool out, essentially, but you want to make sure the patient is not incontinent and they have a predictable bowel movement once a day or once every other day. And there's different ways on how to manage that as well. So why care about sensory and motor changes in this patient population? So if patients can't move, if they're insensate from a spinal cord injury, neuropathy, etc., it can cause skin breakdown, injuries. If they have issues higher up with swallowing, they're at risk for aspiration, which can cause pneumonia and other bad things to happen. And if they can't feel, then they may twist an arm, twist a leg in the wrong way, cause a fracture, etc. So all of these things are important to think about when talking with patients about sensory and motor changes. So what about cognitive changes? This is, a separate lecture or 3 in and of itself, but just to give you a brief overview, these are things including chemobrain, a brain tumor itself, whether it's a primary or a metastasis, etc. Patients commonly experience cognitive impairments. These can be executive functioning, attention issues, short-term memory or long-term memory issues, verbal learning, etc. Depending on what the cause is, depending on the specific impairment that's experienced, there are different medications out there. You can use methylphenidate, you can use amantadine if needed, etc. Donepezil is another one. But it's also important to do a neurocognitive screen. Sometimes specific testing with neuropsych testing is important. So that way you're able to develop a very comprehensive cognitive therapy prescription, so that patients are able to address the specific things that they have in therapy. So that way it's beneficial for them and also beneficial for the therapist. So here's another poll everywhere question, again, to wake you guys up. So what percentage of breast cancer survivors report at least one functional impairment? Okay, good. Some of these are a little bit biased, I admit. Great. So the majority is correct. So what are some physiatry diagnoses in breast cancer that I see and can treat? So anion-induced arthralgia, again, it's its own hour-long lecture, but it's pervasive. It happens in a good proportion of patients, unfortunately, depending on which study you read. There was one that was published. The highest number I saw was 74% in patients who are on these medications. The thought is that a depletion of estrogen causes some of the pain to come more to the forefront, unfortunately, and there's different ways to manage it. A lot of times, and the example that I talked about earlier, patients can have shoulder issues, neck issues, limited range of motion, etc. Lymphedema does not equal cancer rehab, but it is a huge issue in cancer rehab for sure. Patients can also have cording, which, there's a lot of debate about what cording is specifically, but it's a tight band that develops a lot of times on the affected side if a patient has had a mastectomy, and it's thought to be dried lymphatic fluid in lymphatic channels, and it can be quite limiting. It can limit patients' range of motion in their arm. They can also develop radiation fibrosis changes. They may have post-mastectomy or post-lumpectomy pain, which by definition is neuropathic in etiology thanks to the intercostal brachial nerve and other nerves in those areas, and also neuropathy. And in one study, 6 years after diagnosis, over 60% of women experienced at least one functional impairment. And in another study in the metastatic breast population, 92% identified at least one impairment. And it's one of these things, if you don't ask about it, you're really not going to know about it unless you have a very open relationship with your patient. I found a lot of patients, when asked directly about issues, you'll sort of open up the floodgates, which is great. But a lot of times they tell me, oh, I didn't want to talk about it with, my nurse practitioner or my oncologist because I don't want to complain. They've helped me. I'm surviving. I should be grateful. I can manage this. When a lot of times when talking about all these functional things, quality of life things, that you realize that they're not sleeping, they're not able to do stuff at home, they have issues with their kids and partner. So I tend to tell trainees when they're with me, they may come in for one thing, but a lot of times they're like an onion and there's multiple layers going on. So what about in head and neck cancer patients? So not surprisingly, they can have pain. Depending on their surgical history, their radiation history, they can have issues with chewing, especially if muscles were resected or if there's scar tissue. They can have issues with swallowing, which again is bad, can lead to aspiration pneumonia, malnutrition, etc. A lot of them have very dry mouth, which they try to manage by drinking fluids and saliva substitutes. They can have issues with teeth. They can have issues with mouth opening, again, affecting the eating portion of things. They can have lymphedema in their head and neck. They can have speech issues, and the list goes on and on. So what about in BMT? This patient population is unique in that they can develop graft versus host disease, which can affect their joints and their fascia, resulting in contractures, resulting in a lot of stiffness. They can have steroid-induced myopathy, which you do not diagnose on EMG, but it's more of a clinical picture and clinical history. They can develop osteopenia and osteoporosis as a result of the steroids. A lot of times patients with GVHD get referred to me for knee pain. And then I look at their knees and their knees look great. And so I actually look at their hips and lo and behold, they have AVN in the hips, probably from the steroids they were on. This can actually be managed somewhat with physical therapy, depending on the extent of involvement in the femoral heads. However, when I do refer these patients for surgical consultation, just to have a surgeon in their back pocket, for lack of a better word, a lot of times they'll say, I don't want to have surgery right now. And the surgeons will say, yep, just give me a call when you break your hip or when the pain becomes too unbearable. And some of them are able to manage this for a good amount of time before they have to have surgery. So as I mentioned, steroid-induced myopathy affects a lot of these folks. At least 40% of patients with GVHD are affected. A lot of times they get proximal muscle weakness, so pelvic girdle, knee extensors in the quads, the shoulder girdle, etc. A good test that I do with them to see if they have, maybe steroid myopathy is for them to cross their arms and stand up from a chair, not using arm support. And a lot of them are surprised they can't do it. And so what do you do with that? So, these patients may need to be on immunosuppression for an extended period of time. Maybe they need to have recurrent bouts of steroids to keep GVHD in check. You want to get them in to go to exercise program, but a safe exercise program with someone who knows this patient population, is comfortable working with them, and can really, drive home the point that this has to be a daily thing they sign up for to maintain good functional status. Very similar to brushing your teeth, like we do to maintain good mouth health. So I've been talking about a lot of things, but what are things that you can do before patients actually start treatment? So this is where the day 0 and day 1 comment I made earlier comes into play. So even before patients get started in treatment, which we know is functionally going to knock them down, whether that's surgery, whether that's chemo or radiation, you can get them in prehab. And what does this mean? So you want to obtain a baseline functional status. So a patient is coming in with a recurrence, or they're coming in with a new diagnosis of cancer. You want to get a good baseline functional status, see where they are. Do they have pre-existing issues that need to be addressed? You want to improve and basically beef them up, for lack of a better word, get them to a better functional state before you knock them down even more. Prehab has been, a very hot topic in the literature for at least 5 to 10 years in multiple different patient populations. There's different elements across the country in different states and institutions about how this is implemented, but it's been found time and again to reduce treatment-related morbidity and mortality. It's been found to decrease length of hospital stay, decrease readmissions, and improve available treatment options for patients. So what are things that you think about when talking about prehab? You want to address the SNAP factors. You want to talk about stopping smoking. Get them good nutrition. When talking with my patients that I see for prehab, what they ask, what am I supposed to eat? I'm like, protein. They're like, oh yeah, I get mashed potatoes in. And it's like, no, that's not protein. You need, whether that's getting them in with a dietitian or, sometimes they get overwhelmed with appointments, and that's okay, but counseling them of what protein actually is in a healthy way, and trying to increase it as they have increased protein requirements prior to treatment and during treatment. Getting them to stop drinking alcohol. And also changing the P, I think in my mind, as the potato behaviors or sedentary behaviors. But you also want to address the competing factors, things you're fighting against. Are they on multiple drugs? Are they frail? Do they have any sort of cognitive issue, either, from childhood or from prior history, etc., that needs to be addressed? And this is a graphic to demonstrate the benefits that prehab can have. So here, this is the bold line is patients who are, standard of care, don't get any prehab. The dotted line is what we attempt to do in prehab, which is improve their functional mobility, knowing that they're going to have some sort of decline after surgery, after systemic treatment, etc. And the goal is to get them back to their prior functional status, if not even better, once treatment has been completed. So what does prehab try to do? It tries to prevent sarcopenia. Well, what is that? So it's defined as a loss of muscle mass, strength, or function, depending on which source you read. It increases the risk of frailty and bad things happening, like falls. There's different ways of developing sarcopenia. Unfortunately, getting older is something that we all fight against. But other things too contribute to it, whether it's going through menopause, decreased physical activity, not having good nutrition, etc. So how is sarcopenia related to deconditioning? Well, if you're sarcopenic, it makes you deconditioned. It causes worse survival outcomes, which is bad. It increases post-operative and post-treatment complication rates in multiple cancers, and I've just included some here with the references below. And it also increases the risk of chemotherapy toxicity, whether they're going to develop neuropathy or some other sort of complication, including fatigue. So how do you assess for sarcopenia? There's different ways of doing it. I'm not going to specifically order a CT to look at it. They do that more on the research side of things. But in terms of strength and functional tests, you can test their hand grip strength. You can do a 6-minute walk test if you've got the space. You can do a timed get up and go, 30-second sit to stand. You can also assess their gait speed. And there's also validated screening tests, one of which I've included on the next slide. Oh, I thought I included, that you can give to patients to sort of pre-screen for sarcopenia to see, are they at risk for these bad things happening? How do you manage it? You want to get new protein into them. For patients who are sarcopenic, you want to increase their amount of protein, and you can see here that they have increased requirements. There's talk in the literature about maybe supplementing with vitamin D. I know vitamin D was all the craze, 10 years ago, but there's, not hard and fast evidence, but maybe checking a vitamin D level might be helpful, and getting them to a normal range would be good. And then also getting them to exercise, both aerobic, and resistance exercises, and early intervention is best. So how do you manage deconditioning and fatigue, given the prevalence of fatigue in cancer patients? You want to assess their core and lower extremity muscle strength, whether that's through manual muscle testing, transitional movements, as I talked about earlier, gait speed, address any medical contributions. Are they anemic? Are they malnourished, etc.? Talk about them about an ambulatory aid. And sometimes this is quite an uncomfortable conversation to have, but you have to do it. Talking with them about a rollator or something else, and also doing a fall risk assessment with balance testing, asking about loose rugs, all of those fun things. Then you want to develop a treatment plan. Talk about realistic short-term and long-term goals and co-develop a plan, maybe get them into some therapy, etc. So I wanted to save a good bit of time to talk about neuropathy. As I mentioned, it's probably one of the number one things that I see and treat in this patient population. The nerves that can be affected, and I've included this nice picture here to remind us all of the anatomy and microanatomy that I'm sure all of us would like to forget sometimes. But long story short, it can affect sensory nerves, neuropathy can affect motor nerves, and it can also affect autonomic nerves, but fortunately this is less common. When autonomic nerves are affected, patients can develop constipation, urinary issues, irregular heartbeat, etc. So what are the risk factors for developing neuropathy? If you've got underlying neuropathy to start with, right? So if you come in and you have diabetes and you've got neuropathy, from diabetes, unfortunately, you're more at risk for getting neuropathy from chemo because your nerves are already damaged. Being older, something I can't change. Kidney function, also something I can't change all that much. I'm not a nephrologist. But things like smoking, I can change. Things like, seeing and screening, are they developing sensory changes during chemo? Do they need to have a modification to their chemo treatment, etc.? Another thing is coasting, and this is a very fun, unique phenomenon of oxaliplatin. This is where patients get worsening of symptoms 3 to 4 months after treatment. Why does oxaliplatin do this? I wish I could tell you. I don't know the answer to it. But patients a lot of times will say, yeah, after I finished, my FOLFOX, my symptoms of neuropathy actually got worse for a little bit before they started plateauing out. So that is a well-known phenomenon that I like to, educate people about. So how common is neuropathy from chemotherapy? It's overall thought to be underestimated. This is a little bit of an older study. It was published in 2014, but a month after finishing chemo, the prevalence of neuropathy was almost 70%. 3 months after chemo, that prevalence dropped to 60, and 6 months after chemo, that prevalence was 30%. So not great that patients are still experiencing this, right? And why is that? So I talk to patients when they say, well, when am I going to get better? When am I going to get back to that normal? I tell them this is where being short is actually advantageous. I'm 5'3", so I always like to look on the bright side of things because the nerves do regenerate. They regenerate about an inch a month, starting at the level of the spinal cord. So if you think about it, someone who's 5'3", like me, is going to have quicker recovery and repair of those nerves compared to someone who's 6'3". A lot of times patients will say, yeah, the symptoms got better in my hands before my feet. And that's because the arms are shorter than the legs. Similarly, they may say, yeah, I never really noticed I had symptoms in my feet until my hands started being bothersome. Well, it's because we use our hands a lot more in doing dexterity, etc. So I give them a timeline of about 18 months to 3 years after finishing chemo is when patients see the most improvement. Improvement can still happen after that, but that's a good ballpark. And sometimes improvement happens before that, which is great too. But why talk about neuropathy? Why care about it? Well, neuropathy, like I said, affects motor function. So it can cause weakness. It can cause foot drop. It also causes impaired sensation. So not only do patients develop numbness, lack of sensation, or they get tingling, pins, needles, burning, etc., but they can also develop lack of proprioception, meaning that their balance can be totally off kilter, which sets them up for falls, which is, again, really bad. And then when I ask them about it, a lot of times they'll say, hey, now that you mention it, I am a little bit more off balance, or I have difficulty with buttons and zippers. I can't feel things. My handwriting is terrible. All of that relates back to neuropathy, and people get different flavors of it. Not surprisingly, when you have neuropathy, your quality of life is not as good, right? Not only are you falling, not only do you have difficulty sometimes getting dressed and holding utensils and handwriting, etc., but all of those things affect your quality of life. So it's important to screen for it and ask about it and treat it. So again, when walking around, patients who can't feel the floor develop what's called a conservative gait pattern, meaning that they start to shuffle or they start to walk like a penguin. And when they walk like a penguin, it makes them at an increased fall risk. The odds of falling are increased almost by 2. And as I mentioned, they do worse on functional tests. So what is the symptom profile? I addressed this a little bit already, but they can have positive symptoms, meaning they gain something, which may not be a good thing, but they can have itching, tingling, hypersensitivity, etc. They can also have negative symptoms, meaning they lose sensation, they develop numbness, they lose strength, they have weakness, and they can have impaired proprioception and balance as well. So I think this is my last poll question, but which medication has the most effectiveness for treating neuropathy from chemo? Any thoughts?
And while you are all working on the schedule, this question, keep in mind that after this question, you can start submitting your questions to Dr. Knowlton for the end of the session through Poll Everywhere. Thank you.
Great. Oh, goody. So 8% of you are correct. So good. I can teach you something. So there was a practice guideline that actually looked at this specific issue back in 2014 that was published in a little known journal called JAMA, and probably needs to be updated. But ultimately, doing head-to-head comparisons of the different trials that were done, case reports, case studies, etc., they actually found duloxetine outperformed gabapentin. Not saying that gabapentin doesn't help patients, it does, but duloxetine tended to do a bit better. The literature says, and I agree, that going above 60 milligrams for duloxetine doesn't really do a whole lot. You can go above it for the antidepressant effects, but the research has shown that going above 60 doesn't really do anything. Sometimes patients don't want to take an antidepressant, or they are on a long-standing antidepressant and may or may not be willing to switch. I generally contact whoever is prescribing the antidepressant, say, look, could we do 2 birds with 1 stone, work on, the mood stabilizing effects, but also do neuropathic pain. And a lot of times you're able to switch. And there's a great resource on UpToDate that demonstrates the different titration ways to switch from an SSRI or an SNRI to duloxetine. So I wanted to put that out there. Gabapentin is usually my second choice. And then other ones out there, Lyrica, I found, or pregabalin, I found doesn't really do a whole lot. The TCAs I tend to stay away from just because the side effect profile I'm not a big fan of. But what else can you do besides oral medications? So getting them in physical therapy, getting them exercising. Exercise has been found time and again to be extremely helpful, probably by increasing the blood flow through the microvasculature to bring nutrients and take away chemotherapy toxins, for lack of a better word, from the nerves down in the feet and hands. It's also thought to be because you're constantly stimulating when you're walking on your feet, hitting the pavement or tarmac or whatever you're walking on, to really provide some feedback to calm down those nerves. Physical therapy can also help with proprioceptive feedback. So if patients are having balance issues, physical therapy is great. Sometimes getting patients in AFOs or posterior leaf spring, which is the minimalist AFO, if you will, also can help with proprioception and balance. Acupuncture is also great. I have no idea how it works, but some patients swear by it, and the literature has shown for some patients to be extremely helpful. So as long as there's no contraindications for it, I am all for it. So what are things that rehab can do? 1 dose of taxane can actually cause reduced balance and slower walking speed. So it's important to screen and get them in prehab or ongoing rehab if needed. Ways that therapists work with these patients is they start with static standing, adding simple manipulation, then walking. They work on gait training. If patients are having dexterity issues, getting them in hand therapy is great. For my patients who are artists, I tell them to crochet more, knit more, paint more, etc., which they like to hear. Other interventions for patients who have hypersensitivity, getting them in a desensitization program is helpful. As I mentioned, you can trial AFOs. There's other things that are being actively researched, but no good literature to date on its effectiveness, which I've included here. It's also extremely important to talk to them about skin checks. Check your skin. You don't want to have them be, the textbook diabetic patient who steps on something, they've got numbness, they get a nasty infection, and ultimately they end up with an amputation. So I always tell them, have your family member or yourself with a mirror check the bottom of your feet every single day. So what can you do? Exercise, as I mentioned, it helps with symptoms. During chemo, those who exercise experience symptoms less commonly and less severe compared to those who did not. So that being said, I do not yet have an EPIC referral dedicated to cancer rehab. That is forthcoming, hopefully sooner rather than later. But I wanted to put the contact information out there for the people who are great and are patient with me about scheduling. You're welcome to inbox them, email them if you want to have someone to see me. And then also here's my contact information. I currently have clinic in the hemonc side and the surg-onc side here in Chapel Hill, but hopefully we'll be expanding in the near future. So that is it, I believe.
Thank you so much, Dr. Knowlton. This was really great. Thank you for sharing your expertise. And I know you have been personally, I could say a huge asset to my patients. So thank you. So we have our first question coming in. So does insurance cover prehab?
They do, but you have to write the prescription in a way that insurance will cover it. So you can't just say prehab, evaluate, and treat. The insurance company, they've gotten, not so good over the years. But if you write a specific thing like deconditioning or fatigue or proximal muscle weakness or pain and list the pain site, they will cover it in those scenarios, as long as patients have physical therapy or occupational therapy benefits as part of their insurance plan.
That's great news. Our next question, is this program offered at any other hospital?
Yes. So in the state of North Carolina, I am with the UNC system. There's no people yet out at Rex or other locations. My overarching goal in the next 10 years is to create that. We are not there yet because I have to prove my worth. So send me your patients. But at the same time, I do see patients virtually. Also within the state of North Carolina, I have very close colleagues and really friends down at Carolinas in Charlotte. They have a pretty robust cancer rehab program down there as well. And obviously across the country, cancer rehab programs are popping up all over the place.
Great. So there is a question that came through the chat, which I will read to you, but ideal if you can put them through poll everywhere, that would be great. But a question, can you help patients find therapists in their local area to follow up with ongoing PT/OT as needed?
Absolutely. So I have my own resources that I've compiled since coming here and bugging the therapists that are part of UNC. But I have a comprehensive list of all the lymphedema therapists across the state. For physical therapists, there you can go on the APTA website and you can do find a therapist and you can put in as an indicator whether they have cancer or oncology. They're two separate things. It's kind of goofy, but there's a way to find dedicated physical therapy. Another resource I've used is tapping the therapist here saying, hey, do you know anyone in this part of the state, example, for OT or speech therapy that don't have that comprehensive list that APTA does?
Great. So what about acute inpatient rehab unit in Hillsborough? Are you involved in all with that? Do you see patients inpatient or only outpatient?
Yes. So great question. So in Hillsborough, they have their own separate, beautiful new rehab setting on the third and fourth fourth floors. I am there for being on call when I have to cover for my colleagues. We're all in the same department. They do take cancer patients, absolutely, that are appropriate for that level of rehab. Ideally, I will also have a half clinic day up at Hillsborough at some point. I do not yet have the clinical volume, I think, but I'm actually meeting with my chairman next week to discuss that, I think, about opening up a half-day clinic up there. But at Chapel Hill, I see both outpatient patients and inpatient consults. So
Yeah, that would be great. You know, there's a lot of people seen at Hillsborough that would love to have access to keep their care out there. So how often does a patient work with you in your program?
Great question. So it depends on what their need is, and it's very individualized, which is a sort of vague answer, but it's the correct answer. So if I see someone who's coming in to see me for prehab, I will give, an exercise prescription, maybe send them to physical therapy if needed, get them in with nutrition, and I hold them accountable. So I see them back, in about a month or so. For other patients that just, want to talk about back pain, it depends. If I'm recommending some sort of treatment, I generally check in with them sooner. If I'm starting a medication on them, I will check in with them in a couple of weeks to make sure it works. But sometimes patients just want to have me in their back corner. They'll say, I would just want to see you every 6 months to check in. And that's okay too. I always tell them if I don't hear from you, then I assume everything's good. So.
If a patient is sent to AIR post-cancer treatment with spinal cord issues and went home after AIR and still had bowel and bladder dysfunction, I'm assuming the question is, would this be a person or a patient that you would see and follow up?
Absolutely. A lot of times when patients go to AIR, they are sort of in the ideal setting. Everything is regulated, including their food, because they have a certain menu they can choose from. And then when they go home, they realize they're not necessarily being held accountable as much as they were at AIR. So things tend to fall off the rails. So yes, that would absolutely be someone for me to see and help with.
Great. And I echo this comment. It's not a question, but Dr. Knowlton gets rave reviews from all patients we send her. I actually have an additional question before we wrap up here. Probably one of my biggest challenges with physical activity and helping with fatigue, and I feel like I spend an enormous amount of time talking with patients about how to move, how to be active, talking about what works with them and setting a goal with them, and they leave energetic, enthusiastic, and then they come back and they haven't done any of it. So that behavior change, any tips or tricks on how you help patients with that behavior change?
Absolutely. So there's no golden way to do it. I do create an exercise prescription with them, which is a whole separate lecture on how to do that. But there's actually exercise recommendations that were published and, back initially in 2010, were updated in 2019, talking about the 4 tenets of exercise: the fit, prescription, frequency, intensity, timing, and type. And I'll write it out for them. And I'll say, look, you need to put this on your refrigerator. I'm going to check in with you in, say, a month, 2 weeks, whatever. And I'm going to hold you accountable. And I tell them too, it's important to think about, we're all little kids on the inside. So if you do your exercise goals for this week, treat yourself, right? Get the extra cookie, get a pedicure, do whatever you want. I also say, a lot of this cancer treatment is out of your control. You can elect not to pursue it, which is a very different conversation. But most times people, elect to pursue treatment, right? They want to fight the cancer. But a lot of it's out of their control. They can't choose which chemo they're going to do. They can't choose which type of radiation they're going to do, or surgery, whatnot. So I say this is something you actually have control over and has lasting benefits in terms of function and physical health, mental health, etc. So take back some of that control. You can choose not to do it, but that means that you're also choosing to be more in pain, to be more fatigued, to do all of these not so good things. So sometimes reframing it and giving them some of that control back is, I find, motivating. So hopefully.
Great. Thanks for sharing. And we did have a final question come in. I know we are at the top of the hour. How closely do you work with primary oncology teams of the patients you see?
So I am in constant communication. If a patient tells me that is on an AI that they're not taking it and they haven't told their oncologist, I'm the tattletale. And I tell them that. I'm upfront about it. Say, look, don't get mad at me, but I got to tell them this. So I always, there's always closed loop communication, if you will, with the oncology teams. Either for me to ask, hey, is it okay for this person to have an NSAID? Or say, hey, this was brought up. What do you think? Or this issue is new, etc.
Great. Thank you all for attending today. Thank you, Dr. Knowlton, again for sharing your expertise. Thank you to the University Cancer Research Fund, to the Lineberger Comprehensive Cancer Network, the Cancer Center and the Cancer Network, and to our amazing telehealth team who makes all this magic happen. Thank you to Venny, John, Oliver, Andrew, Nadja, and Patrick, and to Tim.